Okay, let's jump right into this. In modern clinical management, there are very few drugs that present as massive of a clinical paradox as Natalizumab. Think about it. On one hand, you've got this incredibly effective agent. It literally halts the aggressive demyelinating progression of multiple sclerosis in its tracks. But on the other hand, it carries this catastrophic potential for JC virus reactivation. In this explainer, we're going to break down this exact intersection of pharmacology and neuroradiology. We'll get into the intricate mechanisms, the risks, and those tricky diagnostic traps that can literally mean the difference between life and death for your patient. So, how exactly does this adhesion blockade work? Well, natalizumab is a monoclonal antibody, and it's engineered to strictly bind to the alpha-4 integrin. You might know it better as VLA4, right on the surface of leukocytes. By hogging this receptor, the drug completely blocks these leukocytes from latching onto VCM1 on the vascular endothelium. And hey, if the leukocytes can't stick to the endothelium, there is no way they're crossing the blood-brain barrier. The end result? A total lockdown. Leukocyte entry into the central nervous system comes to a screeching halt, which is exactly what stops the inflammatory cascade that causes MS exacerbations.
But here is where we run into a major issue: the immunologic trade-off. Yes, natalizumab is an absolute game-changer for preventing that autoimmune destruction of myelin. However, by putting up this massive barricade to keep leukocytes out of the brain and spinal cord, the drug creates a highly localized state of CNS immunosuppression. We are essentially destroying the brain's built-in radar, its ability to conduct routine immune surveillance against latent pathogens. We're locking the immune system out, which, unfortunately, leaves the brain totally vulnerable to whatever might already be hiding inside. And that brings us to the absolute worst-case scenario of this localized immunosuppression: progressive multifocal leukoencephalopathy, or PML. This is a devastating opportunistic strike caused by the reactivation of the JC virus, which is a type of polyomavirus. Because our T cells are locked out and can't patrol the CNS, this latent JC virus wakes up and goes straight for the oligodendrocytes. It strictly targets them. Now, since oligodendrocytes are the cells that actually produce myelin in the CNS, destroying them leads to a rapid, progressive, and very often fatal demyelination of the brain.
To safely manage this drug, we absolutely have to rely on strict diagnostic prerequisites and risk stratification. There are 3 non-negotiable parameters to watch for. First, every single patient considered for natalizumab has to be screened, initially and then every 6 months, for the JC virus antibody. The risk of developing PML absolutely skyrockets in patients who hit 3 specific criteria. Number 1, they are JCV antibody index positive. Number 2, they have a treatment duration of over 2 years, or 24 months. And number 3, they have a history of prior immunosuppressant use. If you're managing long-term biologics, you have to know these parameters inside and out.
Let's establish our radiographic baseline so we know what we're comparing against. Take a look at this classic sagittal flare view. See those pericallosal ovoid lesions sitting strictly perpendicular to the ventricles? Those are the classic Dawson fingers. Nailing down this baseline is absolutely critical. Why? Because when a patient on natalizumab shows up with new neurologic deficits, you've got to immediately compare their new imaging against this classic MS presentation to make a massive neuroradiologic distinction. When we look at the clinical presentation, we have to directly contrast an acute MS relapse with PML. They look very different. An MS flare usually presents with focal symptoms tied to discrete lesions. So you're looking at things like acute optic neuritis with painful vision loss, or maybe transverse myelitis with a distinct sensory level. PML, on the other hand, is a totally different beast. It presents with subacute, progressive, and global cognitive decline, along with generalized motor weakness. It's not focal at all, it's sweeping, it's global, and it is catastrophic. This distinction carries right over to the imaging, giving us an absolutely pathognomonic MRI difference. When multiple sclerosis is actively flaring up, those acute lesions are actively breaking down the blood-brain barrier. Because of that, they're going to enhance with gadolinium contrast. PML lesions, strictly different signature. They show up as asymmetric, non-enhancing subcortical white matter lesions. And here's the really wild part. Despite all that extensive destruction, PML lesions strictly lack mass effect or surrounding edema. No enhancement, no mass effect.
Okay, let's put all this theory into practice with a master case blueprint to test your deep clinical integration. Imagine a 40-year-old female patient with highly active MS. She's been doing great, successfully managed on natalizumab for 30 months. But today, she rolls into the emergency department with new, rapidly progressive left-sided weakness and severe memory deficits. Stop and look at the timeline. 30 months of therapy puts her well past that critical 2-year high-risk threshold. On top of that, her symptoms, Global memory issues combined with progressive motor weakness are huge red flags.
Now here is exactly where the diagnostic trap is set. An MRI of her brain is obtained, and the radiology report comes back showing several new white matter lesions in the right hemisphere. The immediate knee-jerk instinct for a lot of clinicians when they read new lesions in an MS patient is to instantly think, oh, it's an acute MS flare. But if you fall for this trap, you are going to make a fail management error. We need to pause, think critically, and deduce the strictly demanded next best step in management.
Let's simulate actual clinical triage conditions with exactly 5 highly competitive answer choices for our next best step. Choice A, administer high-dose IV methylprednisone. Choice B, initiate plasma exchange, or PLEX. Choice C, switch the disease-modifying therapy to glatiramer acetate. Choice D, perform a stereotactic brain biopsy. Or, choice E, obtain a CSF PCR for JC virus. We've got to use precise, stepwise clinical deduction here.
Let's completely exhaust choice A first. Giving high-dose IV methylprednisolone is the textbook therapy for an acute symptomatic MS flare, right? But in this specific scenario, choice A is a literal death trap. If you misdiagnose this as an MS flare and hit this patient with massive systemic immunosuppression via high-dose steroids, when she's actually experiencing a JC virus reactivation, you will fatally accelerate the PML. It's literally like pouring gasoline on a fire. Just no.
Moving on to choice B, initiating plasma exchange. We can dismiss this one pretty quickly. Yes, PLEX is heavily used in neurology for severe demyelinating MS flares that aren't responding to high-dose IV steroids, or for stuff like Guillain-Barré. But here, PLEX does absolutely nothing to address the actual diagnostic crisis: new, non-enhancing progressive lesions in a patient on a VLA-4 blockade. It's just the wrong intervention for the wrong physiopathology.
What about choice C? Switching her therapy to glatiramer acetate. We can confidently throw this one out. Changing up a patient's long-term maintenance biologic therapy is a chronic management decision. It is completely irrelevant and honestly dangerously inadequate when you're doing acute triage for a rapidly progressive life-threatening neurologic deterioration. We need answers right now, not a medication swap.
Okay, choice D suggests performing a stereotactic brain biopsy. We have to reject this one too. Now, strictly speaking, yes, a brain biopsy could theoretically give you a definitive tissue diagnosis of PML by showing those classic viral inclusions in the oligodendrocytes. But come on, a brain biopsy is incredibly invasive. As the immediate next step, subjecting a patient to neurosurgery with all its massive risks is strictly incorrect when we have much less invasive, highly specific tests right at our fingertips.
And that leaves us with choice E, obtain a cerebrospinal fluid PCR for the JC virus. This is absolutely 100% the correct action. An expert clinician is going to instantly recognize the critical link here. Natalizumab therapy past 24 months plus new progressive cognitive and motor deficits equals presumed PML. You must secure that CSF PCR to definitively confirm the JC viral culprit. This step gets you an accurate diagnosis of the opportunistic infection safely without causing any further immunosuppressive harm.
Let's synthesize all these discrete management steps, because mastering this intersection of pharmacology and neuroradiology is exactly how you prevent catastrophic errors. Number 1, recognize that VLA-4 blockade timeline. Anyone on natalizumab for over 24 months is in the danger zone. Number 2, identify that non-enhancing asymmetric MRI signature that lacks mass effect. Number 3, purposefully bypass that reflex to just hand out acute steroids for an MS flare. And finally, number 4, confirm the JCV reactivation with a CSF PCR.
As we wrap up this explainer, I want to leave you with a final, really provocative thought about the perilous balance of localized immunosuppression. As our biologic therapies get more and more targeted, as they get better at completely blockading central inflammation, we are fundamentally altering the body's natural defense architecture. So how do we as clinicians effectively and safely monitor the silent opportunistic threats like the JC virus that are just lurking behind the blood-brain barrier, waiting for the guard to be lowered? It is a profound challenge in modern neuroimmunology, and one you absolutely must be prepared to face.